Good afternoon, everyone. I'm going to talk about endoscopic modalities for evaluation of Barrett esophagus. But before getting to those aspects of the endoscopy, first we need to talk about the rationale for these endoscopic assessments. Barrett esophagus is the only identifiable precursor lesion for esophageal adenocarcinoma, and it affects up to 5% of U.S. general population. It results from chronic exposure of distal esophageal epithelium that results in metaplastic changes that can go and advance to the low-grade dysplasia, high-grade dysplasia, and eventually intramucosal carcinoma and adenocarcinoma of esophagus. The result of this process is more than 18,000 new cases of esophageal adenocarcinoma and more than 16,000 deaths only in year 2020. So there is no question that we need to intervene on this process. To achieve this goal, we need to develop robust screening programs for those patients who are at risk, and then follow guideline-supported surveillance strategies for patients with Barrett esophagus. Currently, there is no surgical society that has provided any guidelines in terms of management of patients with Barrett esophagus. But there are 5 GI and endoscopic societies that have a pretty robust guidelines when it comes to management of Barrett esophagus. Of them, the 3 that provide the most comprehensive and up-to-date approach are the ACG, ASGE, and AGA. So as you can see, their criteria for screening is very similar. And once, based on these risk factors, we decided that the patient needs endoscopic evaluation, the name of the game is to look more, look better, and biopsy appropriately. That's a theme that you can find in all the expert opinion and the guideline societies when it comes to endoscopic evaluation of Barrett esophagus. The very basic technique is white light endoscopy, but there are numerous studies that have shown that high-definition white light endoscopy provides superior detection rate, both in terms of dysplasia and non-dysplastic lesions. As a result, high-definition white light is now considered a standard of care and is endorsed by all the society guidelines and consensus recommendations. So if you are managing patients with Barrett esophagus, this is the minimum you need to use. The other advances in optical technology includes use of chromoendoscopy that can be done as dye-based or virtual chromoendoscopy. The most commonly dye used is the acetic acid, as you can see in the figure C in this slide, and methylene blue is no more recommended to be used as a dye agent. In terms of virtual chromoendoscopy, basically we are using the technology that has been built into the endoscope to achieve the similar results. Different platforms are available. For this assessment, narrowband imaging is the most commonly used and studied in the United States. What are the advantages of chromoendoscopy? So there are several studies that proven the benefits of it, including this study that is a comprehensive review of 18 studies with more than 800 patients that has shown 34% increase in the diagnosis yield of dysplasia or cancer when compared to white light endoscopy. But interestingly, there is no difference between dye-based or virtual chromoendoscopy. And we know that virtual chromoendoscopy has some obvious advantages, such as adding no cost, negligible time, and no additional risk to the patient. So NBI is developed based on this optical phenomenon that shorter wavelengths have different penetration to the tissue. And since NBI uses anywhere from 400 to 540 nanometer, so is able to highlight the mucosal pattern and superficial vasculature better. And again, there are several studies, including the one in gut in 2013 that showed use of NBI results in higher detection of dysplasia, 30% versus 20%, but with fewer biopsies. Other studies have shown 9% absolute increased risk in dysplasia detection, and 30% relative increased risk. Limitations of the NBI includes moderate intra-observer agreement and the fact that it works best in the hand of expert endoscopists. There are other technologies for virtual chromoendoscopy. For the interest of time, I'm just going to mention the ISCAN and FICE. Other available modalities include confocal laser endomicroscopy. CLE basically processes the reflected light into a high-resolution grayscale image for mucosal visualization at the cellular level. It comes in two different modalities, ECLE and PCLE, that currently only probe-based option is available commercially. It only results in marginal increase in diagnostic yield and requires IV contrast. As a result, ASG and many other societies don't recommend routine use of it. Volumetric laser endomicroscopy, or VLE, is the other option. Basically, 6 centimeters of esophagus would be scanned circumferentially in 90 seconds and provides the near microscopic resolution scan of the esophagus to the depth of 3 millimeters of the layers. Also provides laser tagging that we can target the suspected lesion that way. The downside of it, it requires a very complex interpretation. It's time-consuming. However, some European studies have shown that by incorporation of computer-aided detection, we can enhance the application of this technology with a very good sensitivity, specificity, and area under the curve. But this is a still evolving technology and not currently recommended by any of the society guidelines. Computer-assisted diagnosis is definitely the future. It has the potential to transform our diagnosis and management of Barrett esophagus. The first study came from Netherlands, that Argo's project started by several advanced endoscopists and Barrett esophageal experts in the Netherlands. They used the algorithm using endoscopic still imaging. The initial results showed very high accuracy of 92%. Further studies showed that it has a very good both external and internal validation. But again, this is a very new evolving technology, hasn't been incorporated to any guidelines yet. All the current guidelines are based on endoscopic evaluation, but there is a large number of publications focusing on biomarker testing, and the most commonly and promising technology in this field is probably TissueCypher. TissueCypher uses a multiplexed fluorescent technology that analyzes 9 biomarkers and also morphology of the tissue that is getting incorporated to the sophisticated analysis and results to a basically risk classifier. So by using that risk classifier, we would be able to predict the progression of any metaplasia towards high-grade or high-grade dysplasia or cancer within 5 years. So basically, it's a very solid tool to further risk stratify the patients. High-risk scores in patients who undergone TissueCypher has been associated with 4.7 times more progression than low-risk, independent of age, pathology, segment length, and hiatal hernia. And TissueCypher has been shown that it has a potential to change the management decision in more than half of the patients. So there are some non-endoscopic screening techniques that are basically sponge-based or capsule-based. Again, for the interest of our time, and since the focus is on endoscopic technique, we are not going to go to the details of it, but they've incorporated biomarkers. Several of them are FDA approved, but none of them have made it to any of the guidelines. So the very recent guidelines available currently is the ACG guidelines. Dr. Kolb has developed this 10-step approach to endoscopic evaluation that has made it to these guidelines. It's a very useful algorithm to follow. Basically, we need to identify esophageal landmarks. And this includes squamous-lined esophagus, squamous columnar junction, G junction, hiatal hernia, And this is important because it helps us with future examination. It's beneficial to use distal attachment cap to facilitate visualization. We need to clean the mucosa by irrigation to remove any distracting mucosa from the debris and minimize mucosal trauma. We need to use insufflation and desufflation as needed. Spend adequate time in examining the Barrett segment. Definitely, we need to use high-definition white line endoscopy. It's a standard of care. Use of chromo is highly recommended. We need to document the PROC classification to measure maximal extent of metaplasia and circumferential extent of metaplasia. Use of Paris classification for any neoplastic lesion is recommended. And use of the Seattle protocol, which is 4-quadrant biopsy every 1 or 2-3 centimeter, in addition to targeted sampling biopsy or EMR of any suspected lesion. Thank you.